Dr. Greenblatt, thank you so much for joining us again on DHA's webinar series. We are honored to have you on again as one of the key leaders in the field of functional and integrative medicine, specializing in functional psychiatry. For those who don't know Dr. Greenblatt, he is a globally recognized leader in functional and integrative psychiatry with over 30 years of clinical experience. He has transformed the field through precision-based care, integrating laboratory testing, nutritional psychiatry, and root cause analysis into mental health treatment. He completed his medical degree and psychiatry residency at George Washington University and a child and adolescent psychiatry fellowship at Johns Hopkins. He has written eight books, and is the founder of Psychiatry Redefined, a continuing education platform for clinicians promoting functional and integrative medical approaches to mental health. He lectures internationally on nutritional interventions, biochemistry, and the clinical applications of functional medicine in psychiatry. I could not be more ecstatic to welcome Dr. Greenblatt to DHA Labs webinar series again. For the second time, we are going to be talking about new and natural functional strategies to treat OCD.
Thank you, Caitlin. It's always good to see you and participate in these programs. Okay, why don't I get started? I am going to be talking about OCD, and I don't know about anyone on the call and their practices, but I can tell you in the last 24 hours, I've had 3 contacts with patients and families, 2 that I'm treating, someone else new, and really profound OCD. One story is individual spending up to 7 hours stuck in a bathroom with rituals. Another story, a young adult can't get out of her car to get to work because of compulsions around the texting and the phone, and did they text or post something. And the third one is quite profoundly incapacitated by hypochondriasis and fears of getting sick. Literally in the past 24 hours. And in my world now in practice, doing this for a long time, most of the people that I'm seeing or reaching out are those that have failed traditional treatment and most integrative treatment. So I want to just talk a little bit about OCD. I'm going to try to go fast so we have plenty of time for questions, and hopefully we'll learn something. I've been treating OCD for about 30 years. Much of my career has been inpatient eating disorder, anorexia nervosa with this very high comorbidity of OCD. Running inpatient psychiatric units, to me, it was just quite overwhelming at first when I saw many, many suicide attempts, people being admitted to our hospital because of OCD. There was no other path to stop the obsessive thinking or the ritual. So 10 times more likely to die by suicide. And the tragedy, and the reason why I think this is so important that we discuss, is that less than 10% of individuals receive any treatment at all. Most people go an average of 11 years before getting treatment. And what, if it's not obvious to you, I'll share with you, is that our current treatment model of just polypharmacy and psychotherapy is just not effective enough. So when we talk about OCD, we talk about the O, the obsessions are those intrusive, unwanted thoughts, and then the compulsions are those repetitive behaviors. When I first was in training, we used to couldn't diagnose anyone unless they had the O and the C, compulsions and obsessions. Now there are individuals that mainly suffer from one or the other. And you've all seen and heard these, and this list could kind of go on forever because these are the most common, but any intrusive thought for someone with OCD can be an obsession. But symmetry is certainly common, lining the pencils up, fear of dirt or germs. In adolescence, we see a lot of pathological doubt, also see a lot of religious spirituality. I can't tell you how many, but there's been a couple of individuals intensely committed to a career, one wanting to be a nun, another I believe was a priest, but anyways, just very obsessed with religion and other things, and treating the OCD, and those convictions disappeared. The aggressive and sexual impulses are the hardest to talk about. People that are not typically able to express or have those thoughts can have very violent sexual thoughts and can't get them out of their head. And then certainly the multiple concerns around body dysmorphia, certain parts of their body. It could be anything from a cheek to a toe to a nose. Obsessions. And the compulsions, again, it could be anything. These are the most common: the washing, the checking, repeating, praying, or picking and pulling, from hair to eyelashes to skin picking. So as I shared with you, some of the patients I described cannot function, hold down a job, or this young adult who spent 7 hours in the bathroom. If we think of treatment, we have to understand what causes it, and everybody's got a theory, but our theory tonight is going to be based on biology. We're not going to talk about trauma. We're not going to talk about your parents or psychodynamics. We're going to talk about biology. And when you think about it, we understand there's genetic, profound heritability, almost 65%. We know MRI scans look different. We know there is a partial response to medication that increase serotonin. And we also know in disorders like PANS or PANDAS, or let's just take PANDAS, a strep infection can cause a rapid onset of OCD in 24, 48 hours. That has nothing to do with parenting. That is due to inflammation and strep and brain function. Okay, so how do we treat it? Well, for most of my colleagues, it is a checklist. We ask a lot of questions. We say someone meets criteria for the DSM, and we give them a pill. And in this day and age, we might have a 10-minute med follow-up 3 months from now. Not real effective, no tests are ordered. And my career and what I try to share in psychiatry to find is looking at objective biological tests to enhance treatment, sometimes to find the underlying cause of a major psychiatric illness. And for OCD, sometimes we can do that. So if we think of our current treatment model, we use medications, we use anything that affects serotonin, and it's pretty random, right? If you went to 3 different prescribers, they might give you 3 different ones. Someone has a favorite: Luvox, Zoloft, Prozac, Anafranil. We do know that the medicines that are most helpful are the ones that affect serotonin. And so we get this partial response. 40 to 60% of patients respond. Doesn't mean it eliminates the illness, but they respond. So one of the functional medicine tools in our toolbox, we're not going to have time to talk about it tonight because it's a little more involved, is just increasing serotonin naturally, right? And this is very effective for patients with OCD. So we do that with 5-HTP primarily. So this is a product that I worked on with pure encapsulations for the treatment of OCD, because many patients can't tolerate SSRIs. And here we were trying to provide the precursor to serotonin 5-HTP, all the cofactors, and inositol and taurine all supporting serotonin synthesis. So this is one path of increasing serotonin in the brain. Another option for OCD is literally there's psychosurgery programs and near me that Brown and Harvard both have surgical procedures where they implant devices for treatment refractory OCD. And it's sort of a joke, but it's real. It's happening. And I've spoken to these programs. They have about a 50% response rate. But just think of the desperation that patients and families must be going through to think of surgery. And I just am here to tell you, if you're not seeing a lot of success, that we can do a lot better when we think of functional medicine, understanding root cause. And again, as Caitlin mentioned, we have a OCD intensive. I think it's a 5-hour recorded course, and we had 4 hours of discussion going through these tests to help identify what might be contributing. But tonight, I just want to kind of define the field and share some powerful nutraceuticals that can be helpful. So we're all familiar with the multiple biological, metabolic, environmental causes of abnormal thought and behavior, right? The research has been 25, 50 years. We know inflammation, we talked about pandas, gut dysbiosis, environmental toxins from lead to mercury to copper, vitamin deficiencies, stress, trauma, insulin resistance, and genetics. They all contribute to this wide range of mental health challenges, OCD in particular. But are any of these addressed by our training programs, whether it's psychiatry or nurse practitioner or pediatrics? Anyone treating OCD, there's absolutely no education in root cause. So functional psychiatry addresses that, looks at genetics, lifestyle, nutrition, not afraid to use medications or therapy when needed. But we talked about serotonin dysfunction is a contributor to OCD. And we just briefly discussed that we can use an amino acid precursor, 5-HTP, or the supplement Sero Plus to optimize serotonin. But there are other things that we can do. And one is a very simple supplement called inositol. Okay. And inositol is fun to use for a couple of reasons. One, it's considered part of the B vitamin family, but it chemically looks like glucose, sugar, which means when we offer it to our patients, usually they are very compliant and they say thank you. So we're mixing inositol powder in liquid, could be water, to support the treatment of OCD. Now, what do we know about inositol? Well, it's critical for electrical energy between cells. It's critical for blood sugar metabolism. But for our purposes, it's part of the serotonin receptor, what's called second messenger system. So what does that mean? Well, serotonin is a neurotransmitter. This diagram has dopamine, but it's similar. It's released from one neuron to the next, stays in the synapse, and at the postsynaptic cell, it has a set message, and that's the second messenger system. And here you see in a serotonergic diagram, serotonin is made in the red neuron, and it's released into the synapse. It hangs out for a little bit, and then it hits the second postsynaptic, the blue cell here, and releases inositol. Okay, so when we think about inositol for the treatment of OCD, we first need to appreciate the fact that it works similar to serotonin. It's kind of the second messenger system. Serotonin just hits the receptor on the postsynaptic cell, and inositol does the work. So the good news about inositol for me as a physician, we have research. We have double-blind, placebo-controlled trials looking at inositol. And in the 90s, some of it started in the 80s, but in the 90s, early 200s, we had enough studies where people were able to demonstrate that inositol was helpful in illnesses that were shown to be responsive to SSRIs. Anything that SSRIs were shown to be helpful for. So that was OCD, depression, anxiety. But inositol was very interesting to a number of researchers. So they also looked at other illnesses that weren't responsive to SSRIs, like there are studies on schizophrenia, Alzheimer's, ADHD, and dementia. And guess what? Inositol was not helpful at all. So it does appear that if you're trying to increase serotonin, inositol can be helpful. The original studies looked at depression. These are from the mid-90s, and they gave 12 grams, randomly picked a number, and double-blind placebo-controlled trial. And here, inositol helped for the treatment of depression. When they were thinking about OCD, they said, well, 12 grams helped with depression. When we use medications, we need much higher doses of SSRIs. So they just randomly came up with 18 grams of inositol. That's a lot. It's around 2 teaspoons 3 times a day, 6 teaspoons of inositol. In my career of using inositol for 25 plus years, I've never used 18 grams. But these were some of the original studies, double-blind placebo-controlled trial. And these were individuals didn't respond to SSRIs, and the inositol was helpful. We have other studies, I think I have it here, where they added inositol to the SSRI, and it wasn't statistically significant. Some people noticed improvement, 3 patients in this group. And in my experience, it's about the same. I find it very helpful. We'll go over dosages and how to use it. I rarely add it on to an SSRI. If an SSRI is not helpful, I would titrate it off and think about inositol. So here's one of many cases I could share with you. I was seeing a sibling, and there was a fire in the neighborhood, a significant fire at a house, and this child became increasingly anxious. And although he was anxious since 4, he was never dysfunctional, and but this fire put him into a completely unable to get to school and really get out of the house. And the only intervention was inositol, half a teaspoon 3 times a day. And this, I was treating him as OCD. It was a family history of OCD. He was having, anxiety, obsessional thoughts since early childhood, but nothing that was functionally impairing inositol by itself. So this is where I just want to spend some time to make sure it makes sense. We're talking about inositol powder. We're talking about a nutraceutical. We're not looking for deficiency of inositol. We're using this as a nutraceutical, which means a nutrient that has a pharmaceutical effect, to try to enhance the activity of the work of serotonin by flooding the cerebrospinal fluid with inositol. We know it easily crosses the blood-brain barrier, and we can increase levels. And I start off with probably a quarter or a half a teaspoon twice a day. If you jump to these high doses, and let's say my clinical work is usually around 8 grams a day. Occasionally I get up to 12 grams. If you start with 8 grams a day, they're going to get nauseous and bloating and not really be happy. So you start off with a tiny dose. Each preparation is a little different. It's usually around 700 milligrams per quarter of a teaspoon. So 2.4, um, 2.7 grams for an entire teaspoon. So go slow. It takes me about 2 to 3 weeks to work up to a therapeutic level. There are times, and that's why I like inositol, that it's only used as needed. Someone functions pretty well, whether it be on therapy or medicines or nothing. And then they have periods, whether it's exams, whether it's stress, whether it's moving, whether it's times of the year, that it becomes, the OCD becomes more impairing, and they might just take inositol for that period. There are some individuals that just take inositol at certain times of day. They do fine during the day when they're at work, but at home, they live alone. They start obsessing and worrying about germs, or did they turn the stove off and they're up and down the stairs all day long, all night long. So they only take the inositol in the evening. Oftentimes I might give it at 5 p.m. and then again before bed. So it's very versatile. Okay, so please try to use it with individuals with anxiety. It's much more helpful for obsessive, intrusive thoughts than generalized anxiety. Start off low, quarter of a teaspoon. Again, each preparation might have a different milligrams per teaspoon, so you got to monitor that. Start off slow, titrate. There's no right dose to get to. You don't have to get to 12 grams. I've had people that did fine on 2 or 3 grams per day. It's very simple, easy. And as I said, it tastes good, which means its compliance is not a problem. You know, NAC has been used for years and has profound implications across every major psychiatric illness. Its research is global. And as a precursor to glutathione, it has tremendous implications for inflammation. So besides immune function, the research in psychiatry is pretty extensive, from bipolar depression to addiction to PTSD. But probably the greatest research is with OCD. The mechanisms are pretty significant. Again, besides precursor to glutathione, it supports synaptic plasticity, modulating neurotransmitters, decreasing inflammation, decreasing oxidation, and there's a serotonergic modulation as well. So the research is pretty extensive. Some have been done with patients, some with animals, some double-blind and some not. I think the most important thing I can share with you about the NAC research is the dosaging. Here it was 1.2 to 2.4 milligrams of NAC per day. This was randomized to meds or NIC plus meds. This was for kids with OCD. And here for the repetitive behaviors like trichotillomania, skin picking, nail biting, and here a wide range, but up to the 2400. So again, the research is extensive. There's a growing community of long COVID researchers looking at a augmented form of NAC that seems to have critical importance, but depression, bipolar schizophrenia, and mold, etc. But this is what because I'm sure you're all familiar with NAC, this is what I want to focus on. Many people, actually, I just saw somebody recently with OCD was taking 600 milligrams twice a day for a couple months because someone said it could help with, a physician said it could help with OCD. Well, it's rare that that lower dose will help with OCD. You typically need to get between 2 and 3 grams. Twice a day is minimal, 3 times a day when starting. There are some preparations that are 600 milligrams. This preparation, I think Pure has one that's 900 milligrams. So dosing is the key for NAC. Again, I think many of you are familiar with it. Side effects are usually starting too quickly, and the dose too quickly, and someone getting the GI upset or headaches, or some that might have underlying mold toxicity or other underlying infections can get a exacerbation of symptoms with NAC. So caution there. Okay, so now I want to get to a pretty simple, what DHA is known for is looking at pyroluria. And one of the OCD patients I saw recently, again, multiple doctors, integrative doctors around the country, everybody just added a supplement. So someone said, this is good for you. This is anti-inflammatory. This is good for you. Nobody did any testing. So looking at cryptopyrrole is one of the most important tests that you can do for someone with OCD. One, it's simple and relatively inexpensive in our world. And two, is a high correlation of anxiety, but certainly we see a lot with OCD. Why? Because cryptopyrrole is a likely genetic disorder where we're producing higher levels of this pyrrole that binds B6 and zinc. B6 and zinc is critical for the synthesis of most of the neurotransmitters. For our purposes today, let's just say serotonin. So if we have a functional deficiency of B6 and zinc, we're not going to be support serotonin synthesis. If this goes on for years, and we go back to one of my original slides, genetic vulnerability to OCD, we have a genetically vulnerable kid producing cryptopyrroles for years, slowly depleting B6 and zinc, functional deficiency of serotonin. OCD goes from an anxious kid to a profoundly impaired kid. I mean, it's really that simple. In the functional medicine space, there's not many tests that are that simple to interpret, and the treatment recommendations are simple. So here's the test. The cryptopyrrole patients that I'm seeing with OCD usually have levels 20. We just saw somebody, I think it was 85. And again, just depleting the body of B6 and zinc. So we can talk more, in the Q&A, but there's a baseline level of cryptopyrrole that is produced in the genetically vulnerable individuals, but under stress or illness, it gets worse. So if we, when we find elevations of cryptopyrrole, then we would always have a kit at home and an extra kit. And after we treat it, we make sure if any of the symptoms exacerbate, could be a month or 6 months after we treat it, I want them to peanut cup so we can look at if the exacerbations are associated with increased cryptopyrrole, because then we can be preventative and just increase the treatment. This was just a survey of clinicians who were doing HPL testing. There's not a lot of research, but clinically it is by far one of the most valuable tools that I use to assess and provide a treatment intervention for OCD. But here in this survey, see mostly nervous system conditions, GI symptoms, compulsive behaviors, emotional eating, social withdrawal, mood swings. Anxiety, 91% of the respondents. I'm not a fan of the checklist. People on the internet have your patients do this checklist. If they have a number 7 score, they have cryptopyro or pyroluria is the term used out there on the internet. I have seen every psychiatric symptom that I treat, from anxiety to depression to trichotillomania to exacerbation of psychosis. So the checklists are meaningless to me. Again, anxiety is observed in 91% in this kind of observational study. To me, in our functional psychiatry world, it should be a standard routine test for everyone presenting to your office with a mental health condition. Okay, how do we treat it? We treat it with B6 and zinc, and I'll get to doses in a minute. There are individuals where they respond in 30 days. Parents will tell me anxiety is better, they're doing well. Other times it takes time. I usually repeat the test in 3 months of B6 and zinc because I want to make sure if there is clinical improvement, it's due to lowered cryptopyro. And if not, I want to understand that why I might have to increase it. For many, not all, but for many, if you stop the treatment, symptoms can just come back within 2 to 4 weeks. Okay, what's the treatment? Well, that's why it's easy to talk about, and it's easy when I see these results, because the treatment is B6 and zinc. These ranges here are a little off. The 200 to 800 was just one case. I had to use 800 milligrams, but my treatment usually starts with 100 milligrams of B6 divided twice a day, 50 milligrams twice a day. I don't go above 100 milligrams initially because there is a literature of neuropathy associated with B6 over 100 milligrams. I've seen it. I've treated it. I want to make sure that I rest at 100 milligrams for at least a month and see if symptoms resolve. If they don't, if I can, I get another cryptopyro at 100 milligrams. And if it's still elevated, then I would increase. And I usually average around 200 milligrams of B6. I've had a few patients at 400 and one patient whose mother bought the wrong supplement. And the supplement had 200 milligrams of B6 in it. And it was supposed to be a 25 milligram pill. So she ended up giving her daughter 800 milligrams of B6 by mistake. But within a few weeks, this adolescent who was kicked out of multiple schools, mood lability, OCD, anxiety, eating disorder, challenging young adult, symptoms dramatically changed with this mistake of 800 milligrams. I had her stopped at 200 milligrams. And because I was worried about the neuropathy, this is a number of years ago, I had them taper down and the symptoms quickly came back. And I did it twice over the course of about 12 months. I said, let's try it again. Symptoms came back pretty intensely. So she is what I call, vitamin B6 dependent, meaning requiring a much higher dose. Now, this young woman went on to get a PhD and have a family. I've known this family over 20 years, and she's now just taking a B complex. But for many years, she needed a very high dose of B6 to treat pyroluria. Anyways, usually it's 100 to 200 milligrams. And zinc, it's usually between 30 and 60 milligrams. Rarely would I get to 100 milligrams. I think zinc is often the least important. but we try to give zinc, we try to give B6. We also I also usually give a trace mineral supplement and evening primrose oil, the treatment of pyroluria. Is usually a response, as I said, in a month for most, but some people that have been struggling for a long time, it could be a few months. Just like many other of our functional interventions, testing and retesting is important. So 3 months later, have them retest, make sure cryptopyrrole is normalized. If not, you have to increase the doses of B6 usually, and maybe zinc. So I've somehow been in this OCD world for 25 plus years, and my traditional approach of psychopharm and cognitive behavioral therapy provides some relief. It's usually not sufficient. If I put my functional hat on and look at all the functional testing that we talk about in Psychiatry Refined, we present cases on just gut dysbiosis being directly related to OCD, nutritional deficiencies, B12, folate, MTHFR variants, much, much higher. 2 of those 3 cases I shared with you that I've seen the last 24 hours had MTHFR of the TT variant, homozygous for decreased efficacy. The list goes on and on of how we can dig deeper, look at functional testing to get improvement. And sometimes it's with medication, sometimes it's instead of medicine. You'll find that OCD patients don't always tolerate meds well. Sometimes they're obsessed with the side effects and the OCD gets in the way. Sometimes they just don't have a great response. So when we think of functional medicine for OCD, there's so many opportunities to help our patients. And again, I mentioned some, glycine, it's been incredibly helpful, high doses, 3 to 9 grams. Mentioned 5-HTP, Seroplus, B vitamins, omega-3s, the gut, mindfulness, and actually ketogenic diet. There's been a couple of case studies just came out looking at ketogenic diet for OCD. The punchline, and I'm happy to answer questions, is, rather than guessing, rather than just making educated guesses, why can't we kind of do a more personalized approach based on testing? And here's our fellowship programs. We actually have a pediatric fellowship working with Nancy O'Hara, the pediatrician, PANDAS expert, and she'll be joining us for the pediatric, starts in August. And our adult fellowship starts in July, where we help clinicians learn a functional medicine approach to mental health challenges, OCD being one.
Well, thanks for sharing your insight on that stuff. I think you break down really complex topics in a way that really hits home with a lot of providers who are managing these complex cases where it can be one simple thing. Maybe it is pyroluria, maybe it's something else. So thanks for being with us tonight. I am going to drop right now the link to what Psychiatry Redefined has upcoming. They have an ADHD intensive that's starting in July, and their next fellowship is also starting in July. So if you want to learn from the best, please check out their fellowship group. I am happily supporting that group on as much as I can, and I see what goes on in the live community of your students, Dr. Greenblatt, and your students are brilliant. And it's such a great learning place. So you're not only getting recorded sessions, live trainings by Dr. Greenblatt, live Q&A by Dr. Greenblatt, you're also going into a community of a lot of the top providers who are in the trenches working with these patient populations every single day. So please check it out. I'm going to post the fellowship link now, but I just posted the intensive link before. So please, please, please check out what Dr. G has going on. And we're going to run into the questions. You guys were having some really, really good questions. Kate is wondering, why might higher doses of NAC cause a worsening of anxiety for some individuals with OCD?
Yeah, I think we're very cavalier with our supplements because we tell ourselves, we tell our patients they're natural. And so we just go for that high dose. That's why in this talk, I said start low and titrate up. And I say it every day. And why? Um, Oftentimes, people that can't tolerate NAC might have an underlying inflammation, infection, mold is not uncommon. That's just never been diagnosed. So we often see exacerbation of symptoms with when the dose is too high. So I would titrate back down to when there's not symptoms, and then perhaps look a little deeper at mold or underlying infections.
Great answer. Are SSRIs more effective than 5-HTP or vice versa?
Yes and no. Really depends on the individual, and that's, my students get upset when I always just say it depends because every patient's different. So I can give you stories where some OCD patients took their SSRI and things got better and didn't need anything else. Other patients couldn't tolerate it, and 5-HTP was much more effective. So there's not a good research answer, and there's not a real life answer because everyone's different.
Great answer. I love that. Yes and no. That's how it is. It's biochemical individuality, and it's doing this for a lot of time. That's going to help you uh, really take care of your patients the best as you possibly can. Michael is asking, just how strong is the impact of inositol at bottle dose? Is it a synthetic or food-based supplement? And are there people who don't respond at all to it, even at a high dose?
Absolutely, yes. I would say and that's the nice thing. It's a simple, safe supplement. I usually give it 4 to 8 weeks on a therapeutic dose and then just stop it. Yeah, there is a subset of individuals that don't respond at all. And, I rarely use inositol by itself. That's why the testing is so important, whether it's cryptopyrrole or amino acids or organic acids, because there's usually other things going on, and inositol is just adjunctive treatment.
Let's see. When do you find running genetics or nutrigenomic testing useful in cases of OCD?
I would like to say 100% of the time. Um, well, I will say 100% of the time because, one, I'm always looking at MTHFR variants much higher in OCD. I look at a couple SNPs for poor response to serotonergic drugs. So that could have been something we answered in the first question because there are some genetic SNPs where people don't respond to SSRIs well. And when I know that, we just don't keep trying. And those individuals tend to respond to better meds, different meds, I'm sorry, or the 5-HTP.
Thanks, Dr. G. Would subclinical food sensitivities play a part in OCD? And if so, would they play a small or larger part? Question from Michael.
That's another yes and no. I would absolutely think that food allergies would play a part. Um, and I certainly would, because it's going to cause an inflammatory response. And we know inflammation is a core driver of OCD. For some, it might play a significant role, others a minor role. I've had people, share with me that if they, binged on certain foods, sweet foods in particular, their OCD is worse. So a food diary, food allergies would be part of a workup that we would want to do with someone with OCD.
Excellent. A couple questions came in about the cryptopyrrole analysis and pyroluria. Do you take any considerations to mind when testing cryptopyrroles as far as time of day the blood is done? any confounding variables based on certain food or supplemental intakes or exercises in the days leading up to the collection. Michael, when you order a cryptopyrrole from DHA Laboratory, we give very specific instructions for the cryptopyrrole kit, which is an at-home urine test that includes avoiding certain supplements, and also our testing procedures are super strict as far as what we tell you to do, how we tell you to do it, our shipping protocols and all of that. That's why we have the gold standard in the industry. And I could probably give a 20-minute presentation on how our pyrrole disorder test, the cryptopyrrole analysis, is the gold standard in the industry. But as far as time of day, it should be the second or after. It cannot be the first urine sample of the day. And I think what you might be asking is, are there any considerations when it comes to stress? Because if you're running, a cryptopyrrole analysis with, let's say, a bunch of blood work, could that blood work affect your pyrroles that you're producing? Dr. G, do you have anything to say about that?
No, I don't. The initial one, I don't think about or worry about. I just want a baseline because it just varies. I mean, you'll see if you do your first 10, you're going to get some that are 5, some that are 15, and some that are 82. It's not the baseline, but the follow-up ones I like to do at specific points in time, when they are under stress, when symptoms return.
Mm,
So we try to time the follow-up ones. The initial one, I don't have any recommendations or instructions
yeah,
other
that
than
was a
follow DHA Labs instructions.
Yeah, that was a great answer. Daniel asked, are there any causes besides genetics that can cause pyroluria? So you just touched on one, which is stress. And a lot of people say pyroluria isn't a genetic disorder, it's a stress disorder. So can you kind of give us your take on genetics versus stress when it comes to pyroles?
Yeah, I mean, I think, it's one of the most important tests that I do, but it's probably we have the least research um, on cryptopyrrole. So everything is sort of theoretical, and so just my clinical interpretation of using this test for 25 plus years is that, not everybody in the family has it. Not everyone is under severe stress. So I'm just under the working assumption that there's some genetic vulnerability for the body to be able to produce cryptopyrrole under stress. And then the more stress, the higher the amount of this. And then I believe there's a feedback mechanism as the B6 and zinc gets further depleted. There's, I think, a rapid accumulation. So I think it's my working theory is both genetic vulnerability and stress exacerbates.
Thanks, Dr. G. That's also my theory, but that's because I learned it from you. Pardon me if I can't pronounce this word right. Mayor is asking, is trichotillomania related to cryptopyrrole?
Absolutely. I mean, as a child psychiatrist, we see it's a hair pulling and
Oh,
eyelash
okay.
pulling, and just guessing maybe 20%, 25%. So why wouldn't you, have the child or adult pee in a cup? Um, we've seen trichotillomania related to gut dysbiosis, nutritional deficiencies, but absolutely I have cases going back many years of trichotillomania exacerbated by cryptopyrrole.
Wow. A couple questions coming in on NAC. Is NAC safe during pregnancy?
I've been asked that question a lot, and somebody answered it for me because it's actually used during pregnancy, for certain conditions. So I am not an expert. You should check with your, OB, but I believe it's safe. Yes.
Is glutathione better to take than NAC?
The research is not clear. Do we absorb glutathione and everyone's into the liposomal glutathione? We just don't have the research. I haven't seen it, but we have extensive research across the globe on NAC.
Do you need to titrate off of an SSRI if you want to try inositol or NAC?
Well, NAC could be added to an SSRI easily, and inositol could be added to an SSRI, probably as a kind of as needed as an adjunctive. So you don't have to taper off. You would not want to use 5-HTP or Sero Plus with an SSRI, unless you're watched closely by your prescriber. We use Sero Plus a lot to taper someone off of an antidepressant when they're coming down, but you wouldn't want to just add 5-HTP to an SSRI on your own.
Mm. Would you say that high levels of pyrroles could be a result from Bartonella or mold toxicity?
I'm sorry, say that again, Caitlin.
Yeah, could high levels of pyrroles be a result from Bartonella or mold toxicity? Meaning, if you're suffering from Bartonella or mold toxicity, could that be elevating the pyrroles that you can see in your urine?
Well, the stress of the body, due to toxins, infections, mycotoxins is significant. So it could exacerbate it. Could it cause um, the the problem? I'm not sure, and I don't think anyone knows that, but absolutely would exacerbate any underlying condition.
Thanks, Dr. Greenblatt. Michael is asking if a patient who is clearly suffering from OCD and or pyroluria changes up their diet and other lifestyle factors well, which supplements could they expect to discontinue after a certain number of months? Probably
If
depends,
you're
right?
treating a pyroluria, I wouldn't touch the B6 or the zinc if things are going well for a year. Certainly if they can continue it. And oftentimes, if they really dramatically change their lifestyle and their diet, then some of the other micronutrients, like the B12 or the folate or the magnesium, might be tapered off. But if we're treating pyroluria, try to get to 6 to 12 months on an effective dose. And your patients will tell you when they're ready to taper. um, and just make sure you taper one supplement at a time so you can tell if there's a difference.
Great answer. I think your presentation was so good that we are through with the live Q&A questions. So I'm going to take a couple minutes and ask you a couple questions myself and just make sure that all questions are answered. You guys, if you have any last minute questions, please get them in there. We're going to let Dr. G go in a couple minutes. But Dr. Greenblatt, in your first 5 years of practice, what do you wish you would have known looking back?
When I started, I wish that I understood um, that more testing, the better initially, because in the old days, we were trying to save patients money and we did one test. Oh, let's do cryptopyro. And then if it was positive, okay, we could treat, but if it was negative, what do we do next? So sometimes we did a year of testing to try to find what's contributing to this major psychiatric disorder. Once I started doing all the testing up front, the DHA Psychiatry Defined Panel, once I looked at life that way, I could sit across from some patients who were quite impaired, and I knew their genetics, I knew the nutritional deficiencies, I knew their gut, and I could come up with a plan and prioritize what's the most important thing to start. And I already knew what I was going to do a few months down the road. So I mapped out the entire plan in that assessment. And I think that's been the most effective strategy in my career.
Wow. Is there anything you are not doing in practice today that, let's say, you were doing 10 years ago?
Um, I'm doing less stool testing as a psychiatrist. than I did. And no, I think the field has evolved and kind of catching up with some of the things I was fortunate to be around 30 years ago.
Yeah, and you know that stool answer is pretty common that I when I've asked guests in the past, so you're right on. And final question, can CBS plus plus mutation make NAC problematic?
I am not, I couldn't tell you that either. So I don't, there are
Hmm.
a number of genes that could, so I'm not sure specifically if that particular gene would.
All right, that's fair. Let's do our final question from Daniel here because I want to make sure we are wrapped up by the hour. Is there a way to differentiate whether a pyrrole disorder is chronic or not?
I guess initially no, but there are patients who've had high levels that we've treated and they taper off the supplements either because they went to college and just didn't take them and they did okay. And then there are other patients where they cannot stop their B6 and zinc without getting symptoms sometime within 30 days. So I guess that would be the only way you could distinguish people that can take their supplements and within 3 months, other nutritional supplements treating other things going on easily come off the B6 and zinc. Others, they just keep trying and they just function better with the doses of B6 and zinc.
Thank you so much, Dr. Greenblatt. We are honored, as always, to have you on DHA's webinar series. Again, I'm going to remind everyone who's still here that Dr. Greenblatt has a couple really strong offerings right now. His next fellowship starts in July, and he has an ADHD intensive starting in July as well. So either way, you're going to be getting the best possible education from one of the leading physicians in functional psychiatry, and you should check out what he's doing. He also has his own custom panels, blood work panels, and lab testing panels through DHA. You can always email us and we can add those to your provider portal if you want to order the exact testing that he's using in his populations. And Dr. Greenblatt, thank you so much. I hope you have a great night, and everyone in the chat is saying thank you as well. So we're so happy you're with us.
Great, wonderful to be with you, Caitlin. Take care.
Take care.
Take
Good
care.
night, everybody.